Vietnam. Some 45, 50 years ago. About 50, close to about 50. So take it away, Hawkeye here.
I have a disclaimer. This was all about 50 years ago, and I'm 80 years old, so some things might be a little fuzzy. But I would not be able to tell you what I'm going to tell you if Jane, my wife Jane, had not saved my letters in this folder. This folder was in our attic when the house burned, so it's had hard times. And any data I present will be obtained from the internet. I'm going to make this a little more personal than I ought to, because I had one of the last greatest surgical trainings you could ever have, and it was back when you worked 24 hours a day, every day of the year. And in my case, the general surgery and thoracic surgery was included together. And I actually finished my training 1 year early, 6 years instead of 7. I went to Carolina, then Johns Hopkins, and then did 3 years of internship in residency at Hopkins, then Pittsburgh, when I followed one of my mentors out there. But Johns Hopkins was a fascinating place in surgery at that time. On the 6th floor of the Clinical Sciences building, now called the Blaylock Clinical Sciences building. The offices on that floor, Dr. Blaylock, who is chairman, and for you interns, his roommate and lifelong friend was Dr. Tenzin Harrison, who edited the Principles of Internal Medicine. After his office was Dr. Bonson, who invited me to Pittsburgh, Frank Spencer, who went to be head of surgery at New York University, David Saveston, who went to be head of surgery at Duke, and then Jim Jude, who Dr. Blaylock selected. He had just finished his residency and selected to apply CPR, which they had just developed. Dr. Blaylock made them successfully resuscitate 100 dogs before he let him do it on a patient. And that's the only thing politically correct that I knew about at that time. And the 2 chief residents, up in the, on the 12th floor was Dr. Counterhoven, a retired physicist from Johns Hopkins University, who was interested in resuscitating electrical linemen. And he knew that these young people shouldn't be dead. And when he put the defibrillating paddles on a dog, he discovered the pressure would bump. So that's how CPR, closed CPR, got started. Probably the most famous of all these people was Vivian Thomas, who was Dr. Blaylock's technician. He brought from Vanderbilt with him to run the dog lab. And it's rumored that Dr. William Stewart Halstead tried to get Dr. Harvey Cushing to come back to Hopkins from Boston, and he offered him to be in charge of the dog lab. That's his offer. But it was a fantastic, interesting place to be. The trip to Vietnam, I remember where the sun was, from California to San State, in the same place for 24 hours when we got there. And on several trips, we fueled in Hawaii, Philippines, Guam, Wake Island, and Cambodia. And when we got there at the settlement battalion, the soldier got on and walked to the back of the plane and stood there with his gun. And I asked, I said, "What's he for?" And he said, "That's the piece they here to make sure everybody gets off this plane." This is a modern map, of course. Ho Chi Minh City was Saigon. Bien Hoa is the air base that I flew into, and right next to it, 4 miles away, is our base called Long Binh. The year I was there, 68, 69, the main fighting in the Vietnam War was at Harrisburg, Cambodia, on the Cambodian border. And Vietnam's a very narrow country, up here I think it's 80 miles wide. Where we were, the fighting was about 80 to 100 miles or less from our base. Harrisburg, where the fighting was, most of the time was 40 miles north of Saigon. It was the end of the Ho Chi Minh Trail. Peculiarities of the war in Vietnam as far as medical care goes, the hospitals were fixed installation. The roads were not safe, so air evacuation was used. These fixed facilities had a high degree of sophistication and well-trained surgeons. The helicopters with radio communication could get the patient to the appropriate surgeon. And I worry nowadays about our ambulances going out and starting an IV. They ain't starting IVs, but they bring you mortally wounded people that you had to see what you could do for. It was kind of amazing. Our hospital, the 93rd Evacuation Hospital, was in existence there for 5.5 years. We were about 12 miles north of Saigon. It may have been the largest Army base in the world at the time. I mean, there were 60,000 personnel on the base. It was a target of several attacks in 1968-69. The worst one was the 1968 Tet Offensive. The next worst was the 1969 Tet Offensive. Our hospital, the 93rd, had thoracic surgery as a major specialty. But also on our base was the 24th Evacuation Hospital, which had neurosurgery.
Charlie, what was the relationship between that hospital and the big one at Da Nang?
And what?
And the big hospital at Da Nang?
I do not know. I do not know. We were in Fourth Corps, and our biggest, most important hospital was the 5th Field Hospital in Saigon. And I flew one patient down there for $3. This was our hospital. Once it got pushed together. And some more photographs of it. These revetments were surrounding most of the places where the personnel and patients were going to be. It's corrugated, galvanized steel with sand in between. Here we are in our hospital. These are the helicopters. We had 30 or 40 Huey helicopters, medevac helicopters next to our base. I wasn't going to play you the sound of a Huey thinking about all this. I wonder if there were more than 10 hours in the entire year, day and night, where I didn't hear a Huey overhead. It was a very comforting sound. This was the entrance to our hospital. That was our mess hall. Food was very good. The hospital, as I say, was in existence for 5.5 years. This data came from the internet, and in those 5.5 years, at the beginning, when it had very little work, and at the end, it had very little work. Counting the weekends and everything, 37 patients a day were admitted. 5 were battle casualties. 230,000 or 120-day visited outpatient clinics. We had a capacity of 240 beds. The maximum we wanted to have was 220. We could have up to 400. The maximum we had the year I was there was 278, and that was the Tet Offensive of 1969. Our living conditions were good. The previous soldiers there, a little over a year ahead of me, were in tents, and their biggest complaint about tents was the ground was wet so much of the time. All our medical facilities were air conditioned with window type units. anywhere a patient was going to be. The water supply was rubber tanks that were filled by small tanker trucks. We had running water, we had electricity, but we had outhouses with trees. Our dress was jungle fatigues and jungle fatigue boots. In the OR, most of our surgery was minor, taking out superficial fragments, and we wore just a top, no sleeves, and gloves. If we had a real operation of significance, we would wear a normal sterile operating room attire. The communications, thinking back 45, 50 years, we had a young GI, Army guy, a kid recuperating, and he would answer the phone and then run fetch one other physician they needed. We served 1 year and got 2 R&Rs. This was the first barracks, these 2 buildings. And they're frame buildings with wood floor and screen wire. They were not air conditioned. That's our movie theater. This is Ward 4. All the places a patient might be transported by stretcher were covered and with concrete walkways. That's another view. Some of these upper shots are taken from the water towers. That's where we would occasionally go to watch the war outside. These are mama sons taking the food to the GIs. There were 22 or so hospitals, Army hospitals in Vietnam. The year I was there, the fighting was near us, so we were probably the busiest hospital in Vietnam. Our hospital was the 93rd, of course, and the 24th was on Long Binh, and then the 12th back there in the hospital at Coochie. These were our 2 hospitals on Long Binh. We have every aspect of medical care, I think, except renal dialysis. And I was familiar with doing peritoneal dialysis, so we would rarely do that. We had 2 operating rooms with 4 tables each, so it was extremely efficient. We were allowed to keep our patients as long as we wanted to. So when we shipped the patient out to Japan or Philippines or US, that patient was stable. We had them extubated or had a tracheotomy, and they were eating or had a tube feeding. Our wards were Quonset huts pushed together in the shape of a cross, and in the center of where they all 4 came together, the 2 guests pushed together to make the nursing station. This is a sketch I sent Jane. The helicopter landing pad is here. The emergency entrance is here. Then OR, pre-op X-ray, because you had to use X-ray all the time because of metallic fragment. And then pre-op here, and then straight to the operating room. As I say, 2 operating rooms, 4 tables each. Very efficient. The anesthesiologist could overlook all 8 tables. And of course, all 8 weren't used at the same time very often. But the circulating nurse could supervise 4 tables. Then they went to intensive care, recovery here, and then the wards scattered around. I can't say enough about dust off and medevac, and of course, dust off is the name of the medevac helicopter. And when you see one take off in the dry season, you know what's called dust off. These were Huey helicopters. They had 2 pilots on it. One was flying it, the other was in radio control, and a crew chief who maintained all the equipment on the thing. They could transport 6 to 9 patients depending on how many litter cases they had. You could locate them by either poppy smoke, which is smoke grenade, or a flare gun. Their goal was 90 seconds on the ground. They averaged 30 to 60 seconds. These guys landed in some very hot places. and the only armaments they had was their personal rifle. They tried to be in the hospital in 10 minutes. I read that it took 35. But the average time for being wounded and being on an operating table was less than 1 hour, which is remarkable. The radio network, along with these fast helicopters, made a wonderful aeromedical evacuation system. And the year I was there, over 200,000 men were airlifted to the medical facilities. This is the Huey helicopter. It's a workhorse, I tell you. Our hospital had, we tried to have 9 general surgeons. I was the thoracic surgeon, and I got counted as a general surgeon because the commander didn't want someone wanted me to go somewhere else. So, and I was happy there. We had orthopedic urologists, otolaryngologists, ophthalmologists, anesthesiologists, psychiatrists, internists, oral surgeon. We had one physician deaf the year I was there, and that was the psychiatrist coming or going on R&R. These young men were taken off the helicopter on canvas stretchers, carried by 2 men, and put on stands in the emergency room. Blood was drawn to a needle, and the same needle IV was started. The blood was usually drawn more for a cross-match than anything else. One thing I learned there was to make a short incision in the femoral area, and you could reach in and pull the salvage vein out. You got where you could do it very quickly. And about 3 times, I guess, this is IV tubing. They used to have a little rubber bulb on them, and I would just cut that off and put this in their vein so you could feed them fluids fast. We had nurse anesthetists. They were very good. The circulating nurse could oversee 4 tables, of course. And any injured who could get returned to work in 30 days was taken on a bus to Cameron Bay, which was a very safe place on the coast. Evacuation out of the country, we had Clark, the Philippines, Japan, 2,700 miles, Travis on the west coast, 7,800, and Andrews Air Force Base, 9,000 miles. Our surgical, we worked as teams, 3 surgeons on each team. A general surgeon did the triage, and he decided what should be treated first and what surgeon should do it. We had, I think, the latest and finest surgical instruments and machines that you could have. Excellent blood supply. I mean, we had young patients, lots of blood, energetic surgeons. The year I was there, Vietnam used 38,000 pints of blood a month. This was whole blood in those days. Our surgeons had very good training. These are the stretchers outside the emergency area, right near the helicopter landing pad. And only recently I figured, I think this is a water tank they used to scrub the stretchers. It's probably why it's there. This is taking the injured off the helicopter. This is the pre-op holding area. They are the rubber water tank. I call them rubber. They collapse on their water tank. And this is the emergency room. You'll see here, if you look carefully, I have a picture in mind that I think there are about 5 glass IV bottles here and over here. But that's where the patient would come in. This is the operating room. And behind that door is one of the rooms with 4 tables. These are stretchers ready to take the patient to recovery. And this was a pre-op holding area over here. And then there's another room on the back side here. This is what the operating room looked like. These young men kept this place spotless clean. And the neatest thing about it, is a hole in the floor. You just hosed everything down and went down, but you had to get a Vietnamese to go clean that thing out every once in a while. And I think that's a window air conditioner. Another view of the operating room. There he is washing stuff down the drain. And our scrub sinks were these aluminum boxes. Another view. Our little lower lounge. This was the autoclave room. That's one of the autoclaves. This is the electric generator spot. This was where they stored oxygen. Again, another water tank up there. This was a heavier bunker. I can't remember now if we ever went in there or not, but if the base, our base got attacked mostly by errant rockets. They just happened to land here. We may have used this once, but you see it even has stuff over the top of it in this case. This didn't seem reasonable to me, but it's what I found on the internet. Each ward, not very sick people, a nurse worked in 2 wards. One nurse in 2 wards worked 2 ends, 12 hours, 6 days a week. The intensive care, of course, had more personnel. This was our intensive care. They have higher beds, good, nice quality beds that you can crank up. And in this particular photograph, the patients are all down there, and that other console up down there. Here's the intensive care. The nurses station with, at that time anyway, fairly modern patient charts. This is a regular ward for medical patients or convalescent patients. You can see how close these cots are together. And you see we could have double deckers if we needed to. And our patients were generally young, healthy American males. We had occasional civilians. The Vietnamese were a problem when we had to treat them because their family would not let them be in there without the family being there, and they would feed them and give them all kind of spooky medicines. And if a Vietnamese got injured, the first thing he did was eat some rice and stuff because he knew he wouldn't get it again for a while. I would say one thing, the first time I opened someone, Vietnamese, up, and there were these large tapeworms all over it, it almost made me sick. I wasn't expecting it, but it's a pretty frightening sight. Fragment injuries were the most common injury, multiple wounds, multiple anatomical areas, and they were usually superficial. The AK-47 was a very efficient weapon, as was the M16. They have tremendous kinetic energy, their velocity is such. So if you get shot with one of those, it does a lot more damage than just put a hole through. The extremities were far and away the anatomical area injured. This came off the internet, bullets, mortars, grenades. The attack on Long Binh, the year I was there, Tet Offensive of 1969, the real Tet Offensive that we know about was in 1968. But they tried to replicate it this subsequent year. But our base was surrounded with our tanks. And the jets were flying in case we needed some rockets or something. But the real firepower was the helicopters. And every 15th shell gives off a red light so you can know where they're going. And I tell you, it was an awesome sight to see. It looked like a stream of red coming out of these things. Began at 1 a.m. Our second call, and I don't know who these research surgeons were, they came in at 2:30. Our hospital and others were running about a dozen patients behind. Our team left at 10 a.m. because we'd be first call the next day. Then at 7 p.m. that night, or about 18 hours later, it began to slow down, and we operated on 100 men in these 18 hours. This is unusual, but it was horrible when it happened. We had our surgeons divided into two teams, 12 hours each. One surgeon ran the emergency department doing triage. If the patient was to have immediate surgery, went into pre-op holding and get transfusions and stuff. The more minor injuries took place in physical therapy with minimal nursing attention, and even more minor injuries were taken to outpatient clinic where they were overseen by interns. All medical patients were flown to Japan. The internists did sketchy H&Ps and started IVs. The interns took over all the wards except the emergency department. And special flights were instituted to Japan. The malaria we saw was vivax. We had one patient die from pulmonary malaria. And I was driven crazy about having to order malaria smears with a person with a post-op fever, so I dreamed up this malaria smear Q4 hours until positive. It was very effective. Positive. Other medical conditions were malaria, venereal disease, psychiatric, snake bites, appendicitis, hernias, hepatitis, and vehicle accidents. All the things that young men can get. As I mentioned, we were able to keep our patients as long as we wanted to, which was a wonderful thing because they almost surely made it alive. The year I was there, 36,000 men left the country, up from 10,000 in 1965. Once in a long while, a physician would accompany the patient. Many different kinds of United States Air Force planes were used for evacuation. This is a photograph from the internet. This is a bus from our hospital going to load the patients onto the plane. This is from Wikipedia, this photograph, but it's inside one of the Air Force hospital planes. I think you can see here, I think here are 5 and here are 5 more. There are 10 patients hanging from the roof of that plane here. Most common operation was the treatment of superficial wounds. And any superficial wound like that we left open. You took out any debris, any foreign bodies, any contaminated tissues, cut it out and just left it open. And in 72 hours we would sew it up, part of the debris again if necessary, which is very rare. And they healed beautifully. I'm going to go over a few specific cases. You have to remember these were infrequent, fortunately. This man lost his eye, had a tension pneumothorax, ruptured liver, intestinal perforations, testicle destroyed, laceration of the urethra. His esophagus was blown off his pharynx. His fractures of the tibia and fibula went into his knee joint. Massive hemorrhage from the intervertebral frame in his neck. He got 55 pints of blood. And we nursed him through the night, but he died of fat embolism of his brain. And I think this is the only autopsy I requested that year because I didn't know why he had died. But fat embolism was a problem over there.
Who did the autopsy?
You know, I don't know. I think we had a pathologist that ran the lab. So I think probably he did. I don't really know. These are specific cases: splenectomy, partial pancreatectomy, repair of stomach diaphragm, subcranial lacerated kidney, and a colostomy. We did a lot of colostomies because if the colon is injured, you've got to do a colostomy. replace right and left femoral arteries, and repair the femoral vein, 2 places, 6 hours, 40 pints of blood. And the following day I had to do a fasciotomy on him because he had inadequate venous drainage. This is one of the more horrible ones. But these people are brought to you in terminal condition, so you have to do what you can. This Vietnamese man was run over by a tank. He had a horrible pelvic fracture, bony fragments piercing his bladder, small intestine, rectum, colon, iliac nerve. Huge tear in his thigh running up into his anus, involving his femoral artery and veins. His testicles were exposed. 4 hours and 35, 40 pints of blood. He suddenly died. And
Charlie, in a situation like that, were you able to make the decision without outside influences telling you what to do or what not to do?
yes, as I meant to say starting off, I had the most politically incorrect training you could ever have. And the same was true in Vietnam. And if you wanted a second opinion, you got it from another young surgeon. Yeah, and another thing we learned over there is never let a full-time military doctor operate on you. Why not? Because they don't operate very much. They mostly do paperwork in the office. I did have one at Fort Bragg who wanted to be board certified in thoracic surgery, and he tried to steal all my new cases when the year I was at Fort Bragg. Excuse me. This was one of the saddest cases I had. This officer, he was a captain, I think. He was shot through his liver by an AK-47. And we opened him up, and his liver was like a balloon. You could squeeze the left lobe, and it would all squirt into the right lobe. Never seen anything like it. It was just horrible, so we just had to sew him up. Transverse gunshot wound across the upper abdomen, tearing the liver, right colon, left renal vein, duodenum, left lower pancreas, spleen. Also a fractured shoulder and wound of the neck, knocking out several teeth. And I wrote to Jane, this is what makes you sick, seeing these young, attractive, robust men with their inside virtually destroyed. I'm sick of it all. And then you see the whining, whimpering Vietnamese who are trying to climb on every helicopter leaving the battlefield. What we faced post-op were wet lungs, shot lungs, fatty embolism, renal failure, and bleeding diaphragm. When the census was low, we'd get restless, and the internists and sometimes the cardiologists, when we had one, went into the nearby villages to do diagnostic assistance. I operated on, did several cardiac procedures over there. I don't know how many, probably 6 or 8 in the year. Anything you could diagnose with a stethoscope and operate on without a heart-lung machine. That was basically patent ductus arteriosus of coarctation aorta and mitral stenosis. The problem about mitral stenosis is when you do a commissurotomy, you oftentimes create mitral insufficiency, and you've got no way, if it's really bad, you've got no way to correct it over there. But most of these people, their stenosis was so bad they were nearly terminal anyway. This is a little girl I fell in love with. I fixed a patent ductus arteriosus on her, and you see she's got her arm folded up here because she's cut half in two on the left chest, and that's why I'm holding her by her bottom.
Is that you, Charlie?
Excuse me?
Is that you?
Yes. 50 years ago. Yes, it was. Vietnam displayed the advantages of sophisticated surgical technique combined with rapid and concise emergency care. I wrote my mother, she also saved my life. I have learned some surgical things here. I'm now quite swift. I've learned innumerable shortcuts, many of which have proved acceptable and valuable, so I've progressed rapidly in speed and efficiency, something that would have taken some several years in any other environment. I want to make a few personal comments. One is, every trauma case is different. It was a lot of what we did was exciting. You learned a lot of new tricks. And there were no rules, no BS. You didn't need an operation permit because the U.S. government owns these people. And these were very American men. They didn't complain, they didn't cry, they didn't whimper, they didn't ask for any special favors. You felt good being part of that. I hope we're all like that, all of this together. Everybody's in the same boat together, no complaints. And the United States government was wonderful. They give us anything we needed to save one person. I've got no regrets about that. And they'd even allow us, to do some civilian cases and to help the injured Vietnamese and sometimes even the Viet Cong. But, any questions about any of this? It'll be the answer will be a little fuzzy. Yes, sir.
Charlie, how hard was the transition back from military medicine into the civilian one?
Well, I had a year of boredom at Fort Bragg. But when I first got back home, 2 nights in mid-August, I had to wear a sweater. Two nights in a row until I got used to it. But yeah, it was not hard to transition back, I think, because of the time at Fort Bragg, most of which was very boring.
So I gather infection was not a big problem.
No, it was not. And I don't believe if we kept the patients longer, we might have seen some. We did not see infection, except those who had to be on a respirator for a long time. Because I think these were young, healthy men. And the only thing I really had to learn in the Army, besides getting better at what I did, was how to debride a wound. Which you just cut that wound open until it's all fresh tissue. And fresh tissue, and a young person does not get infection. Didn't see much infection. Yes, Larry?
Charlie, before you went over there, did the military take you and the other surgeons and give you some overview of this is what you're going to find and this is what you're going to have to do? And if so, how much instruction did you get before you went?
We had 6 weeks in early August at San Antonio. I think they call it courtesy training, but they did show you some. But I was number 5 to crawl out under that barbed wire, the machine guns, and I was far away. All of them much younger than I. But it was to teach you about platoons and battalions, how to wear uniform, how to salute, a little bit about the injuries from bullets that travel such enormous velocity. We did a little work on dogs, but not much. See, after my training, I went straight to Vietnam. Basically 6 weeks in San Antonio and then straight to Vietnam, which worked out very well. Any other? Yes, sir.
Question, Charlie. How many cases would you do with that?
It depended on the day. No 2 days were alike. Every once in a while, the biggest case I do would be a napping daiquiri on a young man, something like that. Most of the cases were at night, and they usually dump between 3 and 10 on you at one time. And then you go a couple days with almost nothing. So it's very, very variable. But this was a busy year in the war, I think.
Charlie?
Yes.
You knew, I assume, during a good part of your residency that you were going to be going to Vietnam, right?
Let me see. Well, that was kind of fun. I applied when I got accepted to Johns Hopkins surgery residency. I signed up for 2 years because that residency was 12 interns and 2 guys finished And one of those two was always sent by Denton Cooley, so only one guy was going to finish. But the chief resident said, Dr. Blaylock wants you to stay longer, so I asked the Berry plan to defer me until I finish my training. And then they said yes to that. So.
Did you, the question I was going to ask is, did you do anything different during your residency preparing for Vietnam, or did you just do what every other surgical resident did?
Every day was so exciting to me, I just did it. Yeah.
A question.
Yeah.
Where did all the blood come from? Was that from the
Hell,
health
I had
insurance?
to look that up. I figured they went to the base in Vietnam and said, we need 50 pints of blood today. You know. But they didn't. They did that in the U.S. Early on, some of it came from Asia, but later in the Vietnam War, it came from the States, from the military and their families. Yes, Reed?
Charlie, I was amazed at the statistic earlier that said that 97% of the people there back then came alive.
97% of the injured survived. Yeah. And I mean, that's really pretty astounding because they were brought to you freshly with these horrible injuries. And one or two of them you knew weren't going to make it, but you had to do what you could.
I was amazed because you said nobody started IVs just to get fluids.
Say that again, Reed.
Nobody, the IVs were not started to hydrate them and maintain their blood pressure for these horrible injuries.
It was, and as I mentioned, that sometimes we put in a big catheter. We didn't have those wonderful catheters and invasive needles that we have now. But we would do the cut down in the groin instead of the ankle, for instance, and put a big tube in the intravenous cable. But yeah, but it's amazing the blood we had available. I remember a heart surgeon at Johns Hopkins saying, "Don't tell me there's no more blood." There was no more blood. And we were putting the blood in the top of the heart-lung machine. We'd taken the top off the heart-lung machine and just poured it in there. But it ran out. But he fixed catheterizing for low and then took out her aortic aneurysm at the same operation. So there was no way. Well, I think you guys are, yes.
Charlie, at the risk of being presumptuous, Wendy and I worked alongside Dr. Savston and half of your colleagues from Hopkins at Duke for 10 years. We worked along you here, beside you from 82 until you retired. And I just want you to know, having watched you in the ER, putting chest tubes in 30 seconds and doing all kinds of magic, your skills were equal, if not superior, to anybody you worked with.
Well, you're very kind. One interesting story about Dr. Savston. It was always Dr. Savston to me. You were told never to nasotracheal suction one of his post-heart surgery children. And one day I was doing that. We did it, I mean, because you had to. And he walked up behind me and caught me doing it. And he said, "Charlie, you did a good job of that." I took it as a super compliment. Well, I thank you